And
I love seeing where all these people have gone to college. This is incredible. Great universities.
all right, it was a really good idea to use the chat for that. That's a good way to practice. Sometimes I forget. I just remembered now, and I put in my alma mater. And Andrea, it was University of Chicago. The slogan underneath, like what we would have on our T-shirts, was "Use Chicago where fun comes to die." Because it was way too much work. I still remember it was cold and windy, and we studied way too much. It was a lot of studying. I still remember you would get up really early, especially as a pre-med undergraduate. You would get up really early. It would be like 5:30 in the morning, and you're walking to lab, and the snow's as high as your hip, and you're still going. There's no snow days, nothing like that. I'm sure some people here know what it's like if anyone lives in Chicago. But so great. Thank you for so much for setting this up, everybody, and for being here with me. We have Anissa, Andrea, Becky, everybody here on our side. We're going to go through, this is our final presentation. Has everyone been able to get at least a little bit down for the medication reconciliation? Good. Did everyone find it helpful to think about our medications that way? I know I spent, I had a patient of mine actually that I had a virtual visit with, and they were on this, on the first presentation, and they were able to put everything on an Excel spreadsheet and on the form that was given to us by PMD Alliance. But I hope everyone thought that it was helpful, and just thinking about your medications in a more structured way, hopefully will help us in communication with our own team that takes care of us, and we can take it everywhere we go. So that's our goal. Now, the reason I bring that up is because we've developed a really nice pdcare.org website, because a lot of our questions about Parkinson's disease has a lot to do, number one, with medications, right? What medications am I on? We talked a lot. Our last presentation was very jam-packed with a lot of information about mechanisms and reasons for using medications, the different maintenance therapies, the different adjunctive medications that help prolong that on period. We even talked about the on-demand medications. We talked about the medicines for cognition. We also talked about the medicines for the non-motor symptoms like hallucinations, psychosis that we discussed. And so the reason we have a kind of dedicated website like this one is so that we started having a lot of questions about where can we go? What can we do? What if we need to learn more about exercise for Parkinson's disease? Or if we end up in a hospital, where can we learn more about what we can do to help, how to educate the people that are taking care of our patient, and so that they can learn more. Where's a good resource? And of course, we always say the best resources have to do with the advocacy groups, especially online, right? Like the PMD Alliance website has so much information. We've developed this in conjunction with the PMD Alliance, and it's basically a nice kind of helpful, simplistic kind of PD care website. And we think about it in many ways. The first time we thought about developing this was it was a question about exercise. A patient of ours asked, is there any sort of resources you can give us about exercise? And I said, well, we don't have much, but it would be great if we could just watch a video. And so we have a bunch of different videos here on this pdcare.org website. And if you see online, you'll be able to pull it up, and you can just click on the link that says exercise, and there'll be a bunch of different videos there that are just linked to YouTube, but the ones that we hand selected that were perfect for patients with Parkinson's disease. The other piece here is hospital recommendation and order sets for Parkinson's patients while in the hospital. That can be really, really helpful in addition to information about medication safety. Now we're going to run through that, but here you can see the exercises for Parkinson's disease in one click. So here you see the exercises for posture, the different dances that can be done. We have some balance and stretching, things that work on our core. And then not just motor, strength and balance, we also have information regarding speech therapy. So different voice exercises, speech therapy workouts, and then what's called voice aerobics, not just for our heart, but for our vocal cords. You can exercise those too. So here you can see the hospital care for Parkinson's. Now, it's important to understand the order sets whenever we think about the most important piece for our patients. Now, how is it that we can improve our Parkinson's disease patient experience when they're admitted to the hospital? We can think about making sure that when a patient is admitted to the hospital, that they are, one, given the medication reconciliation form that we all formulated during our first time together, and then two, what's the most important thing that we do in general when it comes to administering medicines? What is it that we all talk about? Is there anything in particular? Do we think that, is there a relationship between feeling crummy and a return of symptoms and what time we take, our different medicines? And here's some, I'm looking at the chat. Yes, you read my mind, everybody, hopefully. Timing, yes, timing, that is exactly right. One of the most important things that I can tell a patient is, if you ever are or need to be admitted to a hospital, or you're being administered medicines by someone else, either in the home or anybody else who takes care of you, that timing is of the essence, right? For a nurse in a hospital, when they have to run through and make sure, when they're taking care of multiple patients on a ward or on a floor, on time for them can be anywhere from 1 hour before or 1 or 2 hours sometimes after the time that it states within the electronic medical record. So if we say that our patient needs their carbidopa levodopa at 4 p.m. and we put it and we state it and we put it in the system, and while we're on rounds, we tell the nurse how important it is. Basically, if they are to administer a medicine an hour late, it's still considered on time for the hospital system. And we run into a lot of trouble that way. At some point in a utopian-like world, we're going to have hospital systems dedicated to Parkinson's disease patients or other patients with neurologic conditions. That's kind of something we've been trying to develop within our own institution, is a center for neurodegenerative disorders, so that we have everyone trained to be able to handle our patients that have chronic neurologic conditions. But whenever we think about it, we think about medication timing. And so it's really, really, really important to resume your home medicines when you're in the hospital as soon as possible. Meaning, once you come in the hospital, it's very important. We also said, along with your medication reconciliation form and along with information from this pdcare.org website, I want everyone to remember to bring their medicines in a bag to the hospital. If you can bring your medicines in a bag to the hospital, we'll be in better shape. We talked about this a little bit, but there might be some medicines, especially with advanced therapeutics, that the hospital system may not have on their formulary. So let's just look at this one page. And this is important when we talk about in-hospital recommendations for our patients with Parkinson's disease. If we say resume home medications as soon as possible, our goal here is to make sure that as soon as our patient is admitted or discharged, that there's no problem with that transition, that there's no change in the timing of our medicine. So this gives us a little bit of tips, some tips when it comes to carbidopa levodopa, Rytary and Entacapone, Azalex, Selegiline, all the meds that we talked about, rivastigmine for cognition, donepezil, memantine, Nuplazid it should be here too. So when we think about the medications, and let's, for example, take a patient that should be given their medicine every 4 hours, it's important to remind all of the medical staff when we're in the hospital that these medications need to be given on time. Now, this has become a major problem for us, especially nowadays with coronavirus. The amount of patients that are in a hospital and can't come with visitors. You know, at Georgetown now they've opened up visitor times to between 3 and 7 p.m., but that's still not enough. Unfortunately, you know, when we think about the amount of advocacy that a patient needs, you need someone by their side all the time, you know, whenever possible, because that can be very, very helpful. So let's give some other tips. Does everyone know what NPO is? NPO means sometimes if you're going to have a procedure within the hospital, basically that you're not allowed to take anything by mouth. Because if you're going to go for a procedure, they want to make sure that there's nothing still being digested in your GI tract. Because if someone were to get intubated for whatever reason for a procedure, if you have stomach within your GI tract, it can increase the risk of aspiration, meaning the stomach or esophageal contents can go into the lungs, especially with intubation. And so it's important that when we know that a patient is at a higher risk of aspiration, even with the medications, it's important that if a patient is unable to take anything by mouth, if they're having difficulty swallowing, it is imperative for our patients oftentimes to get their carbidopa-levodopa. So make sure that our patients continue to take their carbidopa-levodopa whenever possible, even if we have to put in what's called a nasogastric tube. We can put it in a nasogastric tube that'll help us because we can administer the medicines that way. If we also have a patient that might be on a medicine like Rytary, you can open a capsule of Rytary and sprinkle it into something. If a patient is having difficulty swallowing, you can sprinkle it into, we usually say into applesauce, and you can take the medicine that way. It's another helpful tip. There are conversions that we talk about for different medications. For example, this one gives us some tips about the conversion of Rytary to carbidopa-levodopa. And then we always talk about if someone, for whatever reason, is getting feeding through a gastric tube while in a hospital, it's important, just like we talk about when people are taking in food, you know, try and keeping the food intake with that has high protein, keeping that away from the time that we administer medicines. That's something else that we talk about. Now, how do we know, does everyone understand the relationship between our neuropsychiatric state and the possibility of having a confusion or hallucination or psychosis episode with something as simple as an infection? Has everyone heard of that relationship? Okay, this is important. So when people are getting older, as they get older, you know, we talk about the silver wave of older people within our society. When we think about the amount of people that are going to be above the age of 65, in 2030, we're going to have a larger proportion of people above the age of 65 that also have cognitive impairment or dementia. And in people that have some baseline underlying predisposition for hallucinations or delusions or cognitive impairment, or they're on medications like the medicines that we use that can predispose them to maybe have a little bit of the psychosis or hallucinations or delusions that we talked about. Sometimes something as simple as an infection, whether it be an upper respiratory infection, a urinary tract infection, or some other cause, which something simple can sometimes tip our patients over the edge and can lead to a hospitalization. So the first question I ever ask a patient when they tell me, or a patient's spouse, when they ever tell me, oh, my husband or wife or my father or my mother, they're starting to get confused and they're not themselves and they might be experiencing they're a little bit more scared, especially when the sun goes down, or they're experiencing some hallucinations. I hear them talking to people that might not be there. The first question I ask is, do you have a cold or an infection or a urinary tract issue? Is there something wrong? Is it burning when you urinate? Have you had diarrhea? Anything that could trigger your body. And it's important when we talk about the management of delirium or hallucinations. First, we have to make sure that we've reduced the risk or removed a trigger, right? Something as simple as dehydration or a change in the chemistry of the body can alter our patient's mental status. In the winter months, I think we talked about this briefly, but in the winter months when the sun goes down earlier and earlier, what are our patients predisposed to? What happens seasonally? Does anybody know what can happen seasonally in our patients? I can tell you in the summer months, we get a lot of phone calls about dehydration, right? It's hot. Our patients might feel lightheaded. When they go from a seated to a standing position, they might feel like they're going to pass out. Or if they eat a big meal, a hot big meal of pasta, that might make them feel really sleepy and tired, like they need to take a nap. What happens in the winter months? Let's take a look in our chat box. Hold on.
They're saying they're sad.
Yes, sad.
Affective disorder.
Yes, you got it. So we have a lot of, does everyone know the term snowbird? Where people that live in the north and then travel to the south in the winter, it almost becomes an innate process, right? Every winter that passes almost becomes harder than the winter prior to it. And that's something that we have inside us. It's everybody experiences it, but our patients, unfortunately, also as we get older, we kind of become more vulnerable to the seasonal changes of our mind and our chemicals in our body. And so that lack of sunlight, the cold weather, the fact that, we're spending, the sun can go down at 4 and we're not experiencing that light. Remember, light tells our mind, when we open our eyes in the morning and we look at and we open the shades, right? And we do that. And I'm no longer in college at UChicago where it's cold. But I'm in Washington, D.C., but there's still seasons. But I open my eyes and I turn on the lights, open the shades, and I feel sun. The sun tells my eyes and the retinal cells to tell my mind to produce dopamine. So dopamine is a feel-good neurotransmitter. Dopamine is a feel-good neurotransmitter for the morning. In the afternoon, we get a surge of serotonin. That serotonin comes down, and then we get a surge of melatonin. And that's how our circadian rhythm works. But it's very much dependent on light exposure. So things like happy lights in the winter months help us. Yes, try happy light. I have the chat open now, just like I'm just reading real time what everyone's saying. Now, this is a good way to communicate. So the point there is, when we talk about that, and we talk about the predisposition for hallucinations, especially in the winter months, there are now ways to think about treating those symptoms, right? We did talk about Nuplazid or pimavanserin at our last presentation. Yes, there was something about the suggestion to try to help avoid that in the chat. And then it's important whenever we go into a hospital that we know the types of medicines that can be used. There are medicines like rivastigmine, which we use for cognition, which we talked about. Here it says that we always want to make sure that we stay away from, if someone's admitted with a psychotic episode, that they are staying away from the medicines like haloperidol or other dopamine blocking agents, because those can be very dangerous for our patients. We talked about pimavanserin here. And when we talk about another medicine, clozapine, that can also be considered. The problem with clozapine is that in patients that do have psychosis, you have to get weekly blood draws. And here you can see, as part of this PD Care website, Haldol and Risperdal should be avoided whenever possible in our patients. So this is just more information about delirium prevention in the hospital. What did I say about the circadian rhythm and SAD, seasonal affective disorder? Our patients don't only get SAD in the winter months or more anxious Our patients also have a predisposition for psychosis. So what do I tell them? What can I do without, let's not just be a doctor that says, reflexively, take this medicine. Okay, I heard your story. Great, take a medicine. Talk to you later. What else can we do? Have we heard about move to Florida? You know what, Anissa? I think everyone's happy with that. Let's do it. I think we can all, is the PMD Alliance based? Oh, the PMD Alliance is already based in a really nice place, right? It's sunny. The weather is more dry, less humid.
But
so
I'm in Florida, so, I represent Florida.
You're already there. Exactly. All right, perfect. So we'll go somewhere. Maybe we'll split the difference and meet in Texas or something. So that's where we always meet for our meetings, Dallas, Texas, right in the middle. So get fresh air. I always say make sure that you stay on a regimen, get a routine, right? Wake up with the sun. Have you heard about that saying? Wake up with the sun. Don't sleep in. Don't stay up all night and then go to sleep at like 2 in the morning and sleep until 9 or 10 or even 11 a.m. Try and wake up, especially in those winter months, with the sun. If you wake up with the sun and you're up and you're taking advantage of all that sunlight, or at least daytime light, right? When everyone's awake, and you have a routine that you look forward to, and you use a happy light during the winter months, and you make sure that you sleep when you're supposed to and not stay up too late, and make sure you minimize your sleep disruptions, and you do things like exercise and get those endorphins flowing. That's very, very important. And you can see that here. Those are more in-hospital recommendations for our patients. What do I tell all of my patients when I walk into the hospital room and I notice that it's 2 p.m. and they're napping and the shades are down? What do I tell all the nurses? Open PMD Alliance in the South, California too. But what I tell them, I say, we need to get this patient out of the bed and into a chair and put them right next to the window and pull up that shade, right? Pull up that shade and engage them during the day. Call physical therapy, call occupational therapy, call speech therapy, anybody to engage our patients. Once this coronavirus pandemic is over, make sure the patient's family is here, engaging the patients, and try and minimize naps during the day. I said that this is the last presentation, right? So I didn't want to say that at the beginning so you guys would come back, because everyone loves napping, right? But in reality, if we can minimize napping, if patients are having difficulty sleeping through the night, that can be really, really, really helpful for us. And so this is more information about medication safety, the safe medications for our patients with psychosis, pimavanserin. That's the one that has FDA approval for Parkinson's disease psychosis. Quetiapine and clozapine are used as well. Medications to avoid are the typical and atypical antipsychotics whenever possible. This is another thing here about PD care. You can send us comments if you have any questions or comments, and just use this website as a resource. And I know that the first thing that we say always when it comes to understanding our patients and giving them recommendations is we try to provide them with resources. Resources. So as part of the PMD Alliance website, I know you saw all of the resources that were there. You saw that when I talked about medications, I didn't have a slide deck for it, but I will next time, hopefully. But what we will have, if you go just to the PMD Alliance website, you see all the different medications. Having access is important. Having all those forms that need to be filled out, and understanding all the different types of ways that we can help our patients stay on a medicine. The point for this is, and I'll answer some of these questions very soon. The point for all of this is to kind of give us some closure on this workshop. So this was our fourth episode or conversation about it. And if I think about the start to finish, our messaging has been organize ourselves. How do we empower ourselves as patients and caregivers and family members? We organize ourselves so that we can help organize everyone else around us. That's what I've noticed has been very, very helpful. You organize yourself about understanding, right? When we talk about all of the different things that can go wrong, last time we talked about a lot of the things that can go wrong in Parkinson's disease. And the time before that, we talked about the different bad things that can happen, right? Right now, I told you about psychosis. That's a scary conversation. But then I told you what can be done about it, right? Understanding what can go wrong so that you can then empower yourselves with the understanding of what can go right is really the bottom line here. And that sort of positivity and that sort of hope is very, very important for our patients, especially when we think about all of these different ways of utilizing the resources at the PMD Alliance, thinking about this pdcare.org website. Go to it, browse, go to the PMD Alliance as you already have, and browse about all the resources when it comes to exercise, medication understanding, in-hospitalization recommendations. We talked about keeping that MedRec on you. It's like if you leave the country, right? You're going to leave with all of your medicines in a bag, and you're going to have your passport on you, hopefully, and you're going to go and you're going to say, okay, what else do I need? You're going to prepare for that trip, right? I want everyone as they get older, and this is what I tell my mother, who takes care of my 94-year-old grandmother. I said, I always want you to have, a bag ready in case we ever need to go to the hospital, and make sure that you have a little bag within that bag with all the medicines that she takes and an updated list of medicines that can be always kind of updated digitally, right? That's your passport. That medication reconciliation list is your passport to get into any hospital or through any clinic that you go to. And so you do that, and then you have your medicines with you. And that way you ensure that, anything that can go wrong doesn't. And then when you're in the hospital, if you ever do, God forbid, have to go into a hospital system, you have the information in your bag, you hand it, maybe you have several copies of your medication reconciliation form and list. You can hand it to as many people as possible, and then you empower yourself with even more information by going to these resources digitally. So you go to the PMD Alliance, the pdcare.org website, and you learn about, what are the things that, we need to continue to be aware of and reinforce in our minds. Now, that was a run through of a bunch of stuff, and it was about half an hour. And I'd love to answer any questions. I wanted to give more time for questions like we did last time. I thought that was really helpful.
I do think that
So I'm going to take down the slides. Yeah, so we can see all of these faces. And I think that we're going to open the floodgates and let people unmute themselves and ask questions while people gather their thoughts. We do have some that came in through the chat. So to start with, there were some questions about what is an order set, and then how do you actually get the hospital to follow these directions? Should you print it and have your doctor sign it like a direct order? So could you talk about that to start with, Dr. Yaghi?
You got it. So whenever we think about what it is that we need to do for our patients in the hospital, it becomes a little bit tricky. And so we always thought that if we could provide some sort of, an order set is something that's already, it's a list of certain orders that comes as a package that we can consider using whenever we're talking to a doctor. So for example, if I had a patient that came into the hospital with a neurologic problem, there are certain order sets, neuro order sets that already have kind of an outline of things that can be addressed, labs that should be checked, medications that should be avoided. If we need an electrocardiogram or a CAT scan or an MRI, there's this kind of like package within our electronic medical record that becomes an order set. And so what we have here is kind of a metaphor for an order set on the PD Care website. And what it is an understanding of kind of what we went through. For example, if a patient is having issues with psychosis, we mentioned, we talked about the important things within an order set. So if someone is experiencing any confusion, etc., that order set is written in text on the website about things that maybe a patient advocate or a patient partner or spouse can mention to the staff. For example, does it make sense to avoid the atypical antipsychotics in our patients? Having that as part of a list for an order set for our own mind, for patients' partners, so that we can kind of reinforce all of those ideas. Making sure that, for example, if a patient is in the hospital, a patient of ours is in the hospital and has constipation, and it's been a week since they had a good bowel movement, right? It may be beneficial for our patients to think about the resources and these different kind of toolkits that we have and say, okay, maybe it makes sense. Our patient has been feeling pretty bad because we know that when a patient is constipated, they're not absorbing their medicines like they should. And that might lead sometimes to a hospitalization. So what do we do there? We say, okay, let's remind and educate our whole patient population and their spouses and their family and their partners about the relationship between constipation. So as an order set in your mind, you say, okay, I've now looked at this toolkit and it's reminded me to make sure to check with the healthcare team about constipation. So let's try to make sure that if a patient is constipated, we're doing X, Y, and Z to make sure that they're not constipated. Or if a patient is having difficulty swallowing, that kind of text-like order set that we have in the toolkits in the PD Care website, you can say, okay, I know our patient's on Rytari. I know that there's issues with swallowing. And I know that if a patient is having difficulty swallowing, you can open up that capsule and put it into applesauce if possible, as an example. So those are the kind of tips and tricks. They really are kind of tips and tricks for our patient population. What was the other part of the question?
You got it. It was kind of how, you're not in control when you're in the hospital, how to ensure that these orders are followed, that kind of thing.
Got it. So in the hospital, I've learned the best thing you can do as a patient, I'm a patient advocate when I'm a doctor. I just went through a 14-day hospitalization for my 94-year-old grandmother in my own hospital. I made sure she came in, I rolled her in through the emergency room, and I kind of, from start to finish, I became her patient advocate. The number one thing you can do is educate yourself, use these resources, read, learn, go to the websites like we talked about for the PMD Alliance, the pdcare.org website, and just try and learn and soak up as much information as possible. And continue, anyone that you encounter, continue to talk to them about the patient. So if the patient has Parkinson's disease, remind everyone, this patient has Parkinson's disease. He or she is special. The way we handle Parkinson's disease is different. You have to take care of its patient. Medication timing matters. For example, if it's been half an hour and since a patient was due their medicine, you can advocate for the patient and say, it's very important that our patient, and you can go to the nurse's station, for example, and say, this patient needs their medicine. Is it possible for you guys to come by and please administer the medicine? So that sort of kind of reinforcement and reminding in a nice, but sometimes persistent way is important.
Absolutely. So people have put some other resources in the chat, like the Parkinson Foundation's Aware and Care Kit. And also Nancy Floodberg, our friend in San Diego, put the Parkinson's Passport. And Nancy, I see you unmuted yourself. Did you just want to share about that, or did you have another question?
Well, a couple comments. I think Dr. Torres-Yaghi has done an outstanding job of, I'm shocked you did it in half an hour, giving us an overview. I apologize that I was not able to attend the other presentations, but I definitely plan to. I am on a national team to develop hospital policy and procedure, and just FYI, Epic, which is one of the more common electronic databases, has been working with a couple of members on our team directly. One, a person with Parkinson's, and also a hospital staff member, to develop the order set Dr. Yaghi is talking about. So it's going to be rolled out in sections instead of overwhelming medical staff at once. And the first is going to roll out at UCSD, hopefully this February. And then I'm based in San Diego. Within San Diego, we are then going to approach the other hospitals on Epic, using Epic, so that they can roll it out too. It's in its initial stages, but it is so heartening to know that we are finally getting to where we should have been a long time ago. So this pdcare.org, I think, is fabulous. I just texted my webmaster and said, get this up on the web as soon as you can so that we can roll this out. And I plan to take and use some of our support groups to share what you all have just done. I cannot emphasize enough how important it is to take what he said literally. I've just been looking at the website. It's outstanding. My husband, John, has been hospitalized 18 times since in the last 9 years, and he's had Parkinson's for 20. It is not a safe place to be at present, and that seems very counterintuitive. And you have to get educated. I think your comment that you said, understanding what can go wrong, is so important in order to understand what you can learn and do right. That's critical. We're all on different journeys. You don't know whether you've picked Mount Whitney or you've gotten Everest. You have to fill that bag, that backpack, with as much information as you can. And I think these presentations that have just been done are probably some of the most critical to your success, living successfully and well with Parkinson's. Get yourself the Parkinson's Aware and Care Kit. You may, and if anybody, I'm gonna just stick this in here. If anybody needs a kit and you need information on how to do it, I'm putting my email in here. Just contact me. I'm happy to navigate that.
We appreciate that. And as you guys can tell, Nancy knows her stuff. So thank you for that comment and adding that. I wanted to, you mentioned, especially right now, the hospitals are, not safe. There's been a couple questions in the time of COVID, how now it's harder for patient advocates to be there with their loved one. Sheila said they're concerned in the case of hospitalization, she wouldn't be able to monitor her husband's meals and meds and all that. I know you can't solve all of the problems and answer all of our questions, but any advice, in these times of COVID, Dr. Yaghi?
A great point, a great question. Thank you, Nancy, for all that great input too. Yeah, we have, unfortunately, until we're able to get through this as a society, there are going to be restrictions upon us to keep everyone within the healthcare institution, patients mainly, including the hospital workers, but patients mainly, safe. And so they have hospital restrictions. And so just recently, our hospital was able to open up for certain time frames in certain parts of the hospital only, but that has made it very, very difficult. There were times, and it's been a while now, there have been hospitals that have a no visitor policy, and that can be very hard, especially with what Nancy had said, that the hospital can be in a counterintuitive way not so safe of a place, especially for our patients that need someone by their side, oftentimes all the time. So you can remind the healthcare staff about the disease that we're dealing with and about the importance of medication administration. So the best thing we can do is use any mean that we have. So my mother has 3 sisters, and they are persistent, and they became friends with the nurses over the phone, and the nursing station, and the nurse manager, and everyone over the phone. And they made small appointments, and they tried to stay connected on a daily basis with everyone within the hospital. And that's just a firsthand experience of what works. That communication still does exist. Most hospital systems understand that right now, because of the lack of the ability for visitors to be there and our transition to the virtual world, oftentimes they would set up appointments to speak with doctors virtually while in the hospital. And so I think having the conversation with the staff or the healthcare team taking care of a loved one that's in the hospital is the first step. Say, how can we communicate with you? How can I communicate with the nurse coming on? How can I communicate with the new set of doctors that tend to rotate all the time, right? Because that's another issue. It's kind of constant communication that becomes very important. So I think if anything in terms of empowerment, I saw use FaceTime. I know it's 2020. I still remember at the beginning of this pandemic, I was like, please, why is no one listening to me? We can just use virtual everything, in 2020. We can have like a little, robot on wheels with a camera on it. I mean, why aren't we here yet? I was feeling frustrated that we weren't able to necessarily pivot to that point. But agreed, find any means to be able to, whether it be phone call, traditional, FaceTime, or any sort of virtual platform to communicate with the healthcare team. They are very open in many ways to that. They should be welcoming to more information. The other thing, though, is to organize your mind. I said a lot about organization, right? Try and help with their workflow. That becomes very important. If you can be organized and help the team with their workflow, they're going to use you as an advocate, as a resource for them when anything happens. And that's what I told my whole family when my grandmother was in the hospital. I said, write down, if you have questions, write them down. Try and be succinct and efficient with the questions so that they are very busy in a hospital setting. And so if you can be succinct, but at the same time effective, that can really go a long way, especially short check-ins. I think are more important than long encounters with less frequency. So shorter check-ins that you get that sort of longitudinal light communication.
Okay, very good. Ken, I think you've unmuted. Did you have a question, Ken?
Yes, I'm very interested in who is responsible for the PD Care website. There's no information on there as to who sponsors it. There's no about us. There's no copyright. There's nothing. And frankly, I'm always suspect when I don't see that information up front because well, I won't go on, but can someone answer that question?
Yeah, I can answer. So it was basically done by our team at Georgetown. You're right. It doesn't have any sort of kind of white labeling like a Georgetown thing. It's something that we used in our practice. And just for our own patients, just for a resource for them. And we can use it. There's nothing there that necessarily needs to be copyrighted from our end, but I think all that information is information that we would give verbally to our patients. And it's still in its infancy. It's going to continue to be developed.
Even still, just as someone who spent 30 years doing website design and teaching it, I think it's something that, even at the bottom somewhere, it doesn't have to be copyright, but just an attribution so that we have a sense of the credibility. Frankly, if it comes from a pharmaceutical company, I always think that there's an axe to grind and they're trying to promote ultimately, as altruistic as they may sound, they're ultimately trying to promote a product. And from a university, I, don't have that suspicion, but I have more of a sense of, oh, they're trying to help us all, regardless of political or economic persuasion. Do you understand what I'm saying?
Yes, that's a very well taken point. And that makes a lot of sense. And we should take that into consideration, definitely. And same with with kind of any resource that you look for. That's a point well taken. You have to make sure that you understand the source of the information, make sure that it's a trustworthy source that is an impartial voice. as Mr. Schiff explained, because you want someone to be giving you, or the group that's creating the content, to be giving you objective, scientific, validated information. You got it.
I don't go to Flacco's Parkinson's blog to get my information.
That's a good point. Exactly right.
So if I knew it was coming from you guys, then I say, oh, okay, I'm going to pay attention to this because I know that Dr. Torres-Yaghi is on his stuff. So I want to hear what these people have to say.
It's a very good point.
And if I can give you any hand with that, I'd be happy to.
Thank you. And really good advice. Really good advice.
All right.
Thank you.
Appreciate that. So let's see. I think Janet might have a question queued up. Are you out there, Janet?
I am. Thank you. I have two questions. One, when you were talking about the Nuplazid, you mentioned that Nuplazid should be taken at night. And I'm curious about that because my husband's on Nuplazid and he takes it in the morning. And I'm wondering if there's a reason why you suggested it be an evening medication. And the other question is if you could talk a little bit more about the, I don't know how to pronounce it, the rivastigmine patch.
Yeah. Okay. So it's a two-part question. Very good question. So what we say whenever it comes to medications, so it really depends on the doctor that's prescribing it. And so I would go back to the doctor that prescribed it and ask them, there might be a reason why they prescribed it at whatever time during the day. Sometimes it's a vague recommendation when they say take once a day. It can be either morning or evening. We tend to do most of the time the medicine at night, just based on timing and the way the medicine goes up and down in the body. Similar to some of the other medicines that could be given at night because there may be some reason. Like if you're going to take a medicine that might make you sleepy, you might take it at night. But the reason we say take it at night or during the day for pimavanserin is just based on kind of how we've been prescribing it within our practice. But there might be some doctors that do prescribe it in the morning or in the middle of the day. But just ask them. That's a good question to ask. And that's important in general with all of your meds. Don't just be okay with once a day. You want to be as succinct and as specific as possible. If a doctor says, take this once a day, say, what time? Push back and ask the question because timing, as we know, is important, right? If we think rasagiline, for example, rasagiline is a medicine that we do give in the morning. First thing in the morning, that's our first medicine. So we say, take that first thing in the morning, along with your carbidopa, levodopa, and whichever formulation that you take it, for example.
Okay.
If we're going to give a medicine like escitalopram, which is an SSRI, which can be for depression or anxiety, we tend to give that in the morning. Although there might be some people who come back and say, hey, when I take this medicine, I don't feel like it should, I feel tired with it. I feel maybe like I'm sleepy with it. Say, well, if the medicine's been working for you, why don't we try taking it at a different time so that you don't feel sleepy? So it's very much dependent on that relationship and that conversation with your physician.
Okay, thank you.
You got it. That was a great question. And then the second piece was about rivastigmine. So rivastigmine is a medicine that is a acetylcholinesterase inhibitor. It is a transdermal patch that can be worn and replaced every day. There's 3 doses for it. There's a lower dose, a medium dose, and a higher dose. That's how I say it. The lower dose is, the reason I say that is because the numbers are hard for everybody. 4.6, then 9.5, then 13.3. And so, but we tend to, with any medicine, start with the lowest dose. The reason acetylcholinesterase inhibitors are important is because they can help augment the amount of acetylcholine that we have in our body and in our mind. And that chemical is important for cognition. So if a person is experiencing cognitive impairment as part of their symptomatology, everything that's related to their Parkinson's disease, if cognitive impairment is a factor, we talked about at some point in this workshop series about the understanding about everyone's cognition, right? We even put up the Montreal cognitive assessment that was determines whether or not someone has cognitive impairment. In our clinic, we try and make sure that we don't neglect that aspect. We try and almost prop up the cognitive piece and keep it on the same tier as the motor system. So we don't want to neglect it, and we want to address it. And a lot of the times, one of our first agents for patients that have memory loss or cognitive impairment is rivastigmine, because there is data to suggest that rivastigmine is a good medicine when it comes to Parkinson's disease cognitive impairment.
Okay, thank you.
You're very welcome.
Okay, Dr. Yaghi, there's not much time left. There's been some questions about anesthesia and pain meds. Is that a quick question for you to answer, kind of what to avoid? Okay, go for it.
So that's a good point. When it comes to, so it's tricky. It's a tricky answer. So we have to address pain as physicians. It's very important. You want to make sure that our patients don't have pain. However, at the same time, you want to make sure that you're treating the source of pain, right? So for example, if a patient has tight muscles, crampiness, dystonia-like feeling, with dystonia as a symptom of Parkinson's, let's say in the leg, it's not uncommon for us to have like one crampy foot, right? Or one crampy calf, or toe curling that can be painful. And it can be maybe on the side where we have more tremor, right? We know Parkinson's can be one-sided, can be bilateral, but it's not uncommon for us to see kind of some sort of hemi-distribution, asymmetry when it comes to those symptoms. So that tightness sometimes can be pain. So we don't necessarily treat that sort of pain with any medicines for pain. Sometimes we will treat that sort of pain with maybe more medicine that augments the overall control of the motoric system, right? So we would use our medicines, the ones that we know that are good for Parkinson's. Sometimes that reduces pain. So the reason I bring that up is because we do have to be careful with medicines that do target pain, because in the elderly population, if we use medicines that target pain, then we might get into trouble because they can worsen confusion, they can cause somnolence, they can create an effect, a negative impact on our respiratory drive, and multiple other physiologic factors within our body can be affected by pain medications.
Very good. Well, yeah, I think that's the end of our time. So I'll let Anissa close it out.
Right. Thank you, everyone, for joining us today. And this conversation is so important. And I'm so glad that we had it with you, Dr. Torres-Yaghi. You're obviously very knowledgeable about the problem, very compassionate about it, see it from the patient and care partner's perspective. So I very much appreciate your time and all the time you've given us for this whole series. So thank you.
You got it. Thanks everyone for listening. Thank you for all those great questions, for all the great advice, for all the great comments. And I really enjoy speaking with you. And I know I always wish we had more time, but truly, you know, I want everyone to feel good, to feel empowered, and to feel positive after these sorts of presentations, because like we said, what Nancy had said about, you know, it's true. You know, we talk a lot about what can go wrong, and that's scary. And I don't always like talking about that because there can be a lot of negative feelings. But really, if we translate that into understanding what's happening so that we can figure out what to do about it, I think that's the number one goal here. The more we know, the more we do, the more we learn about these diseases that have to do with chronic neurologic illness. And the more we do in terms of clinical research, you know, that's another big piece. You know, there's a lot going on in clinical research for moving things forward to helping our Parkinson's patients. And one more piece there is that, you know, a movement forward for another neurodegenerative disease oftentimes can be potentially a movement forward for Parkinson's. So if we see a breakthrough therapy for Alzheimer's disease, that might be helpful, perhaps, right? There's no black or white answer there, but that might be something we could think about for Parkinson's disease, and vice versa. There's a lot that has to do with understanding all of our diseases as chronic neurologic diseases that affect the brain. So it's so nice to talk to everybody. Thank you so much, and I'll see you soon, one day soon. We'll set it up.
If you missed any of the other ones, we do have them up on our YouTube channel. And let's wave goodbye to Dr. Torres-Yaghi. Thank you so much for joining us. Bye-bye.
Thank you. Bye-bye.
Thank you, everyone. Bye-bye.